everybody to the Trigeminal Neuralgia support group meeting for this quarter. Just a little bit of background information on logistics, and then I'll introduce our speaker. So this is one of our quarterly meetings. The next meeting will be the second Wednesday in March. It's the same time. It'll be 5:30 p.m. Likely still be on a webinar at that time. So look for the topic and the meeting invite for that meeting as well. The format of this meeting will be a presentation by our guest speaker, and then she will be able to take some questions and answers at the end. And if you want to submit a question to the speaker, you can use at the bottom of the screen the question and answer icon. If you click on that, it'll allow you to submit your questions to the speaker. Just really want to, it's a pleasure to introduce our speaker tonight, somebody who has worked closely with lots and lots of facial pain patients, and someone that I use routinely for consultations for my patients as well. She's excellent in terms of this type of management. So this is Dr. Niushen Zhang. She graduated from Yale University with a Bachelor's of Science degree in Molecular, Cellular, and Developmental Biology. She then obtained her MD degree at NYU School of Medicine. She completed both a neurology residency and then a fellowship in headache medicine here at Stanford University. And she's currently a clinical assistant professor of neurology in the Division of Headache and Facial Pain. She's the fellowship director for the Headache Program Fellowship at Stanford, and she's the chair of the Complementary and Integrative Medicine Special Interest Section for the American Headache Society. So she's going to speak today on kind of the non-surgical managements of trigeminal neuralgia, giving a broad overview and talking about medical management. So pleasure to have you, Niushen. Thank you.
Thanks, Dr. Chang. Very nice to be here. And it's always a pleasure to work with you, one of the great surgeons for TN. So it's my pleasure to be here. So I thought for this evening's talk, we'll talk about some of the background and some of the basics of TN first. Then we'll sort of delve into more of the details about the standard treatments that we currently use. And then we'll end by talking about some of the emerging therapies that we have in the pipeline that is actually quite exciting. So in terms of what is TN, typically we describe it as this recurrent, unilateral, brief electric shock-like pain. We expect it to be limited to the distribution of one or more divisions of the trigeminal nerve. Usually it's in the second and third divisions. And, TN is actually a pretty rare condition. It affects about 1 in 25,000 people. So if anything, we often see it being overdiagnosed in the patients who come to our clinic. So in our clinic, we never take a previous diagnosis for granted. Every patient starts with a blank slate, and from there, we take our own history of the illness. We do our own exam before deciding what diagnosis is actually most consistent with what our patient is experiencing. And what our patients often have is actually migraine or some other headache disorder that has facial involvement. So, that can be kind of tricky to diagnose, and it can often be missed in other clinics. So we're very careful about making sure we're not missing anything. Otherwise, we think of typically for TN, we see a little bit more of it in women than in men. And it usually occurs in people after the age of 50, although, clearly it can occur in people who are younger as well. In terms of anatomy, the trigeminal nerve is primarily a sensory nerve that gives sensation to the face, but it also contributes to the motor function of our muscles of mastication when we chew. And it's one of the 12 cranial nerves that comes from the brain. And the trigeminal nerve actually starts in the pons, which is the upper section of the brainstem. It extends into the Gasserian ganglion, which is basically a sensory nerve bundle. And then the nerve, it divides into the 3 branches, which we were just talking about. And, in the world of headache and facial pain medicine, we have something called the ICHD, which is the International Classification for Headache Disorders. And it's basically our dictionary for all headache and facial pain disorders that have been described. And so here, this is how TN is defined in the ICHD. So basically, a person has to have at least 2 attacks of this one-sided face pain, and it should have at least 3 out of 4 of these characteristics that you see listed. And very importantly, the neurological exam of our patient should be normal. So for example, for anyone who comes to our clinic with face pain, we always do a very thorough cranial nerve exam, especially looking at facial sensation. So with TN, your face may feel more sensitive to touch or to cold or pinprick, but there should not be a decrease or loss in sensation. So when we do see sensation loss, then we think about like a neuropathy, which means that there may actually be damage to the nerve itself. And, I think it's important to clarify some of the terminology that we use. With classic TN, even if there is physical contact with the blood vessel pushing on the nerve, we typically don't expect damage to the nerve that would cause neurological deficits. So with classic TN, it can be caused by neurovascular compression, or it could be idiopathic, which just means that we don't have a visible structural cause. And the terms type 1 and type 2 are older terms, but a lot of doctors still use them. So I think it's good to clarify. Type 1 is the purely episodic pain that comes and goes, whereas type 2 is a TN that has this concomitant, persistent facial pain. So you have this persistent background pain that's often punctuated by more severe episodes of pain. And then, of course, we have secondary trigeminal neuralgia that's caused by a structural lesion other than like vascular compression. And, again, we want to rule out any other potential physical cause for the pain. And, with really any kind of facial pain, we will almost always get an MRI brain with thin cuts through the brainstem to get a better look at the brainstem and the nerve. And also we get an MRA head to rule out any blood vessel abnormalities that can cause face pain. And, there's still a lot we don't know about why TN occurs and what the underlying mechanism is. What we think is happening is that something is causing the nerve to be hyperexcitable and for it to generate impulses in places where it should not be set off. So when you think about therapies and, keeping what we just said in mind, you can think of all of these therapies that we use as basically ways of calming down that hyperexcitability. And based on the evidence that we have, here are the medications with the best evidence to the least amount of evidence. And so in the rest of the slides, we'll go over some of these in more detail. So starting off, we have carbamazepine. I'm sure many of you are familiar with this. This is our best studied treatment for TN. It's been established as effective through quite a few randomized controlled trials. There's a pretty wide dose range. So some of my patients do great on just 200 milligrams once or twice a day, and others have to, go up to 2,400 milligrams a day. And, before we place someone who is of Asian descent on this medication, we always do genetic testing for the HLA-B allele, which is associated with an increased risk of developing something called Stevens-Johnson syndrome. It's pretty rare, but it's a serious disorder if it happens. It can basically cause like blistering and damaged skin and mucous membranes throughout the body. And can be life-threatening. So some of the more common side effects are dizziness, balance issues, nausea, vomiting. And typically, we or the patient's primary care doctor needs to track the patient's metabolic panel, which tells us their sodium levels, We track their liver function and complete blood cell count. And this is to make sure the patient doesn't drop their blood sodium levels or drop their white blood cell count or have elevated liver enzymes. And then we have Carbazepine. We think of Carbazepine as the friendlier version of Carbamazepine. It's backed up with pretty good evidence, but doesn't have as many studies as we have for Carbamazepine. It comes with some of the similar risks like Carbamazepine, but typically we see less of those more common side effects like drops in blood sodium. Usually there's less dizziness and drowsiness. And typically, we find that people just tolerate it so much better. So we actually use it as our first line oral medication for most of our patients. So sometimes, the side effects of Oxcarb and Carbamazepine are both of them are just too much for our patients. So especially many of our elderly patients experience a lot of sleepiness, sedation on the first two meds. And so lamotrigine is an alternative that is much less sedating and can be effective for some people. So this is one that you have to start low and go slow because, again, there's this rare side effect of Stevens-Johnson syndrome. And evidence-wise, and also clinically, it's not as effective as the first two, and it can take a long time to increase the dose to an optimal dose. But it is typically very well tolerated by our patients. And in psychiatry, this medicine is actually often used as a mood stabilizer. And it's something that we use for migraine prevention as well. So it wears a lot of hats. Then we have Baclofen. And, this is sort of next tier evidence and more of a second line or adjunctive therapy that we use with either Carbamazepine or Oxcarb or lamotrigine. So I'll usually start people on this nightly, then increase them up to twice a day or 3 times a day. And drowsiness is the main side effect. So you also need to taper off of it very slowly because of possible withdrawal side effects like seizures and hallucinations. Pymazide, there's some evidence that supports the use of Pymazide, which is an antipsychotic medication. We rarely use this because of the potential side effects that include arrhythmias of the heart. It can have anticholinergic effects, which can cause like dry mouth and urinary retention, which no one wants. And some people get Parkinsonism on it, so they become slow and rigid. So you have to be really careful of this. And, this list of medicines we will sometimes use as adjunctive therapy, but they really don't have much evidence behind them. And out of these, I would say I probably use gabapentin the most frequently because it actually does help many of our patients and it's pretty well tolerated. And it has the plus of it just doesn't really interact with other medications that our patients may be on. And, for our patients who have pain that's really, really difficult to control, we will primarily turn to using combination treatments, such as combining Carbamazepine or Oxcarb with Baclofen, and then maybe adding on top of that gabapentin as well. So some of our patients may end up being on 3 different therapies at once. In terms of the IV treatments, our clinic typically doesn't do much of this, but sometimes the pain management clinic will actually admit patients for IV Phenytoin or lidocaine infusions. There's not much evidence for it, and the success that I've seen with it is kind of variable. And then the last item that I included is the botulinum toxin type A injections. I don't know if you guys are familiar with this. It's also called Botox. And the toxin is basically a naturally occurring neurotoxin that's made by bacteria called Clostridium botulinum. And this type A is the most commonly used subtype that we mostly use for cosmetic purposes. but it's also FDA approved for treatment of chronic migraine. So these are our patients with like 15 headache days or more in a month. And the kind of most well-known mechanism of action of Botox is that it inhibits muscle contraction. But obviously, that's not why we think it helps a lot of the pain syndromes that we use it for, such as migraine. We think that the toxin actually inhibits other neurotransmitters like norepinephrine or other pain molecules like substance P or Cgrp. And these are things that play a role in how we sense pain. And so by inhibiting the release of these neurotransmitters using Botox or botulinum toxin, it can lead to pain relief. And there's actually been a handful of studies done on Botox and TN. So for example, there was this open label pilot study on about 11 patients. They followed the pain using like 25 to 75 units for these patients, and about 8 out of the 11 patients found that it was helpful in reducing 50% of the pain and intensity over 2 to 4 months. And then there was also one randomized double-blind placebo-controlled study, and it showed that about 18% of the people in the Botox group had 50% reduction in pain score at 12 weeks, whereas 15% of the placebo group showed about the same. So not a big clinical difference between placebo and Botox, but there was a statistical significance there. I have to say though, looking at all the Botox studies, I think one of the main issues is that there is no standardized approach or protocol to using it. Some kind of follow the pain, others will use like a grid-like system. The dosing is different in all of the studies. So that's, not that helpful. And then in clinic, in the real world, the reason we don't commonly use this is because insurance does not cover it. So out of pocket, it is often thousands of dollars, and we try not to, put our patients through that. So the kind of last sort of exciting thing, I think, on the horizon, it's not quite here yet, but I think we should talk about it, are things related to CGRP. So if you're not familiar with this, CGRP stands for calcitonin gene-related peptide. It's all the rage in migraine treatment right now. You may have seen the commercials for these. They're once a month, one injection that you do at home for migraine prevention. And the CGRP molecule, it's essentially a pain molecule or a neuropeptide, and it's widely distributed in the brain. So for example, it's in the hypothalamus, the thalamus, the brainstem, and in the trigeminal vascular pathway, CGRP expression is highest in the sensory trigeminal ganglion. And we know that activation of the trigeminal ganglion cells releases CGRP. So in this article that I referenced from another Dr. Zhang, this was published actually this past fall. They took 45 patients with TN and 30 healthy controls and treated each group with Botox, which is thought to decrease the release of CGRP. And afterwards, they tested the plasma CGRP concentrations and found that patients who responded to Botox had a significant decrease in CGRP levels in their blood. The point the authors are trying to make here is that CGRP is likely involved in the pathophysiology of TN. And this is exciting because we now have several different monoclonal antibodies against this CGRP molecule that are FDA approved and have been shown to be effective in migraine prevention. So, if trials show that it can be helpful for TN, then we have another viable therapy. So if you look on clinicaltrials.gov, you'll see that there is this phase 2 trial that's led by the Danish Headache Center. They're using the monoclonal antibody irenemab, also known as Aimovig. I'm sure you've seen it on TV. They're conducting this placebo-controlled, double-blind, randomized proof of concept study to evaluate the efficacy and tolerability of the CGRP receptor antibody, irinimab, in treating people who have TN. So currently, this is a phase 2 trial right now. So that means that they're looking at, does the drug work, and whether they need to do more assessments for safety. And so the estimated completion date is fall of 2021. And, again, this is really exciting because we really haven't had that many new or effective medications for TN come out for a while now. So this would be a true breakthrough if results pan out, and it could potentially be a great treatment option for our patients. And that is all I have. So happy to answer any questions. Let's see. Let me see, one question. Oh, several questions. I'll just go down the line. So we have one question. Have there been any studies on the effectiveness of Pamelor on TN? So that's a really good question, Robert. A lot of neurologists like to use Pamelor or nortriptyline. It's a TCA antidepressant that we'll often use for like neuropathic pain. There actually aren't any good studies on this for TN, surprisingly. But because we use it often for neuropathic pain, like for people with diabetic neuropathy and entities like that, some people end up using it for trigeminal neuralgia, but the evidence is really not there. So I hope that answers your question. And then we also have another question. What are your thoughts on CBD THC for the use of facial pain? Great question. There aren't really any studies on this. It's not evidence-based, so in our clinic, we don't recommend that. In the migraine world, we're starting to see kind of more and more clinical evidence that people who use cannabis products consistently or frequently might actually develop something called medication overuse headache, or they get rebound headache from using cannabis products too frequently. So that's something we ask people to be careful of, but it's not something that we recommend for any of the headache or facial pain disorders because it's not evidence-based. And then let's see, I have another question. Which clinic at Stanford would I need to get referred to in order to be eligible for CGRP if and when it gets approved? A very good question. So if it gets approved, you're more than welcome to come see us at the Headache and Facial Pain Clinic at Stanford. This is a medication that we're very familiar with and have prescribed a lot of for our migraine patients. So if there's evidence, if FDA approves it for trigeminal neuralgia, it's something that we definitely would love for our patients to try if appropriate. Let's see, any updates for ATN treatment? Oh, for atypical, is that right? Atypical trigeminal neuralgia. As far as I know, I haven't seen any recent articles for that. Dr. Chang, I don't know if you've seen anything more recently?
Not really, other than, I think now there's been a lot more focus on, I'm trying to be more diligent in classifying the subtypes of the facial pain.
Yeah.
To try to help the patients, but I've not seen anything specific on this.
I haven't either, yeah. Okay, let's see. Oh, my mouse is stuck. I'm sorry. Let's see. Sometimes it has a life of its own. Oh, there
I can read you the question if you want me to. Is that if you?
I just got it. Thank
Okay,
you. I see that I have anesthesia dolosa, had 6 TN surgeries and had TN for 18 years. The pain flare started October 3rd and 10 ER visits since then. All that has been recommended is methadone or RG ablation. Anything I can do? So, I'm so sorry for what you've had to go through, and that's a lot. I hesitate to give out any specific advice. Again, we're more than happy to see you in facial pain clinic. And again, like we were talking about earlier in the talk, we always like to start from scratch and get your whole entire history and do our own exam and review all of your imaging before we actually, give any specific treatment advice. So if you'd like to be referred to our clinic, happy to see you there. Let's see. Oh, okay. Sorry, mouse issues. It just keeps disappearing on me. Let's see. I don't know if, I think Dr. Chang, you might be the right person for this.
I can read you the question. So
okay.
Next question from Eugene. He says, I had gamma knife surgery 2 years ago and I was pain-free for 14 months. After that time, I started to have numbness on the left side of my face. Is there anything that can be done to reverse the numbness?
Not that I know of. Sometimes nerves heal on their own, right? And they the sensation can come back. I don't know what your experience has been, Dr. Chang, with that.
Yeah, I think so. When the trigeminal nerve carries the pain fibers and the sensory fibers, and when you do a destructive procedure like gamma knife, which actually is designed to damage the nerve to achieve pain relief, it's common to get to have some of the sensory fibers get impaired as well, and that's what causes the numbness. And so those patients, what we do know anecdotally is if you have numbness, you're more likely to have longer term pain relief from the treatment than those patients that don't have numbness. But if there's not really a lot to do for the numbness, unfortunately, but if the numbness improves then on its own, which sometimes can happen, that does mean there's a potentially higher chance of pain coming back as well, though. The next question for you, Niushen, is I was stable on gabapentin, 2,400 milligrams a day, Baclofen, 40 milligrams, and looks like lamotrigine, 100 milligrams. One attack after this was helped immediately by increase of lamotrigine 1 to 150. However, I'm having short-term memory loss and orthostatic hypertension. I am a patient of hypertension. So I guess there's just this, I don't see a question here, but maybe the comment says, can you get side effects of memory loss and blood pressure changes on higher doses of these medications?
Typically, no. So if we're talking about gabapentin, Baclofen, lamotrigine, typically you should not be experiencing memory loss or orthostatic hypertension. Those are serious concerns, and I would either check in with your primary care doctor or see a general neurologist for the memory loss component. Yeah, but those are not typical things that we see with those three particular medicines.
Okay, the next question is from Amanda. It says, why has there been so much less emphasis on atypical trigeminal neuralgia treatment and trigeminal neuropathic pain? I've been to Stanford, UCSF, and independent pain care providers in the Bay Area. Only the independent providers are trying new regimens. It's very frustrating.
Yeah, I totally hear you, Amanda. Part of it is, again, like we were talking about in terms of epidemiology, it is a rare disorder. So, I think there's less funding in terms of like research funding for this. Drug companies often are investing in, making medicines for this, unfortunately, whereas like migraine, because it affects, 40 million American adults, I think a lot of the companies put in a lot of time and money in investing in that. In terms of, trying new regimens, the reason we at Stanford, at least, stick with the kind of standard treatments is because we have to practice evidence-based medicine. So if it's something that's not FDA approved or it doesn't have, good enough like studies or evidence behind it, then we really can't formally recommend it. But I hear your frustration, definitely.
Another question from Ginger. What are the side effects of CGRP therapy?
Oh, good question. Yeah. So CGRP therapies has been very well tolerated by most people, which is a big plus for it. What we do see happen is that some people get GI issues with it, specifically severe constipation. We think that CGRP, we find it throughout the body, especially in the gut. So we think the monoclonal antibodies have some effect on that. So for my patients who already have severe constipation or GI issues, we're very careful about either holding off on starting it or talking to their GI specialist before we start it. Other things, because it's an injection, you can have injection site reactions, so redness, soreness, pain, that kind of thing. Otherwise, we really don't see other short-term side effects. The thing we always have people keep in mind is that these are very new medicines. So the first time we really started prescribing them was about 2 years ago. And we have about maybe 3 years of safety data on it. And beyond that, we don't know what potential long-term side effects there could be. So we do have to keep that in mind.
Okay, great. Next question from Chuck. If the source of the facial pain is suspected to be the result of dental work, can the nerve heal or is it permanently damaged?
I mean, it's a good question. It depends on what happened, right? What kind of dental work and, how much damage was actually caused. Nerves are resilient. Nerves can, heal themselves over time, but sometimes it is irreversible. I don't know, Dr. Chang, do you have any thoughts on that?
I think this is always a tough challenge because, oftentimes we see kind of also the opposite where it's true facial pain, but it's thought to be dental work. And we've all seen patients that have come in with a lot of dental work done in attempts to alleviate the pain.
Yeah.
I'm sure there are patients that, have the pain that come out of dental work. And maybe this is actually would be a good topic for one of our next quarterly support groups to have Gary Roberts or one of the Stanford dentists kind of come in and give a talk on their experience with this. It's definitely one of the confounding areas of face pain, because not only can it be just facial pain versus dental work, but sometimes patients can have both going on, and maybe their face pain wasn't an issue until they had the dental work, and then now the trigeminal nerve has kind of got irritated twice, maybe once from something else and once from the dental work. So this is always a challenge to sort out. I don't have a good answer for this one in terms of how to separate out the two.
Yeah, I agree.
Okay, next question for you. This is from David. So how often in your experience do you see trigeminal neuralgia go away spontaneously? And if you were on pain medicines and had no pain, how would you know if your trigeminal neuralgia had gone away other than titrating down on the medications and seeing what happened?
Yeah, that's a really interesting point, David. I don't actually know the stats on this, like the official stats. It's rare that in our clinic we see it because often we do see the most refractory of cases. When I do see it happen, it's in the setting of titrating down the meds. Because you're right, like how are you going to know if you don't come down on the meds, right? With trigeminal neuralgia, I find it to be very interesting because it's very unpredictable. Like one of my favorite cases is there was a 92-year-old lady who came to see me a couple years ago. What was interesting with her was that when she was in her 40s, she had TN and she was treated with, I believe, Tegretol or Carbamazepine at that time. She took it for a year and things were very well under control. And that's why she, dared to taper off of it. And when she tapered off of it, she didn't have any pain. And she was actually pain-free from TN for about 50 years until she turned 92 and this pain came back again, and she came back to see me. So, I don't know the answer to the first part of your question, but for the second part, I would have to say you do have to come down on the meds in order to truly see if the TN has remitted and gone away.
Great. Okay. Couple more questions. Amanda asks, what research has been done about the impact of hormones on trigeminal pain?
In terms of TN, I personally haven't seen any studies specifically looking at hormones and TN. Most of the studies that we see with hormones and head pain have to do with migraine. And in migraine, what we see is that the change or the fluctuation in estrogen level is one of the many potential triggers for migraine. So I think that's as close as I can come with that one.
Okay. The next question is probably, maybe we can both weigh on this. So John asked, statistically, what is the success rate for medication versus microvascular decompression? So maybe the broader question is, what would you quote a patient that comes into clinic with true classic trigeminal neuralgia pain for the first time in terms of, when you give them medication, what are your expectations?
Correct me if you feel differently, Dr. Chang, but I always think of surgery as, something that can have potential risk, and that, with all of our patients, even when we do see the neurovascular compression, we usually do try oral medications first, because a lot of people actually respond very well to even small doses. So why would you put them through a potentially risky surgery? I don't know the stats for this, but we almost always try our patients on meds first before we actually refer to surgery.
What, like if a patient comes in and hasn't been on medication and you're starting medication, what would you tell them in terms of like expectations of would the medicines, would the first medicine work? Is it 3/4 or is it higher than that, or?
Yeah, it depends on which one, right? So usually when we do the Carbamazepine and or the Oxcarb, at least in the clinical trials, the success rate is great. I think it's like over 50%, 60% of people respond actually really well to it.
Okay,
Yeah.
and then how often, kind of as a follow-up question, how often do you end up having to put patients on a second or third medication versus having the first one work for a while, kind of right out the door?
Yeah. In our clinic, again, we see a lot of patients who are more refractory and it's difficult to treat. So we often do put people on a second one, such as like Baclofen or gabapentin or both. But I've also seen a lot of success with just, an optimal dose of Carbamazepine or Oxcarb.
Okay.
Yeah.
And then Chuck, in terms of the microvascular decompression, or actually John asked about the microvascular decompression. When I see the patients, they've almost always been screened heavily by neurology, and so I see basically kind of the patients that are optimally good candidates for microvascular decompression. So in that sense, there's a relatively high chance of at least some initial pain relief, probably about 85%. But again, all the patients that aren't surgical candidates have already been screened out. So, and then as Dr. Zhang mentioned, there's always a surgical risks as well that need to be weighed. So we usually, the standard practice is you need to fail medical management first. Either poor, inadequate pain control or just, overwhelming side effects before we would consider the surgery. And I guess, Dr. Zhang, would you say a patient has to fail 2 medications before you would consider a procedure, or? like what constitutes medical management failure?
Yeah, that's a really good question. It's actually very patient dependent. Usually it's, two things. Are the treatments effective, right? So typically we want them to try at least 2 to 3 of the medicines to make sure, that it's actually effective or not effective in controlling their pain. And the other is, can they tolerate the side effects? So, I can give you an example. A typical, person that I would send to Dr. Chang would be someone who, this was a guy from a couple years back, very nice gentleman. He was on carbamazepine, high dose carbamazepine, high dose gabapentin, and high dose baclofen. It was still not controlling the pain very well, and he could barely drive and, barely stay awake and just couldn't live his life. That was a no-brainer. Like, send to Dr. Chang, and by the way, he is cured. He's doing awesome. Thank you, Dr. Chang. And then I had a more recent patient who his pain was actually very well controlled on trileptal or oxcarb. It wasn't a very high dose, but he has a high functioning job where he needs to be like very mentally sharp for his job. And that medicine just made him just not quite himself. Like he wasn't as sharp. And that for him was actually a deal breaker, even though the pain was under good control. So, we talked a lot about, risk versus benefit, and he understood, there are risks with the surgery, but we ended up having him see Dr. Chang. He ended up getting the surgery and ended up doing really well.
Yeah, I agree. A lot of it is patient related because patient specific. Like, for example, I remember one patient. He was like he was one of those pilots for one of the Silicon Valley CEOs, and he's flying private jets into San Jose Airport, and he's like, I can't be sleepy trying to land the plane
at all, right? Yeah.
And then another patient, he drove one of the Caltrains.
Oh, wow.
Caltrain conductor driving the train, and he said, I can't be sleepy driving the train. I got 500 people on the train.
Yeah.
So sometimes that matters. And the last comment I want to make, John, on this is that I actually like to see the patients for surgery that have tried a number of the medications, because whether they respond to the medication is a very good predictor for me of how they will respond to microvascular decompression. So if they've responded well to Tegretol, for example, Carbamazepine, or one of the other medications, but they maybe had too many side effects, those patients actually have a higher chance of success with microvascular decompression than somebody that comes in and says they've tried 3 different medicines and none of them worked. Because in a sense, if you respond to medication, you're almost declaring yourself as having the true type 1 classic trigeminal neuralgia that does the best with the microvascular decompression. So a couple more questions for you, Dr. Zhang. Chuck asks, is there a link between atypical facial pain and occipital neuralgia?
That's an interesting question. Not that I know of based on the evidence and research. They're very separate. I don't know if you're familiar with occipital neuralgia. That's more of a kind of back of the head pain. So they're not actually connected. They're 2 separate nerves, essentially. So as far as I know, there's not really a connection. I will say this though, when we see neuralgias, they often are that sort of hypersensitivity of that nerve or hyperexcitability of that nerve. And, we can see that sort of simultaneously in one person. Occipital neuralgia is actually very common. So common things being common, it can happen kind of in the setting of someone having atypical face pain as well. I hope that answers your question.
Okay, last question for you. Both high-dose carbamazepine and carbamazepine react with hydrochlorothiazide to cause extremely high blood pressure and low sodium. How often do you see this type of reaction?
That's interesting. I don't think I've recently had any patients on that specific combo of meds. Obviously, if it's causing very high blood pressure that's very dangerous, and we definitely don't want that to happen. So that would be an intolerable side effect, and I would, what I would do is connect with their primary care doctor who's managing their I'm guessing it's HCTZ, the hydrochlorothiazide that you're talking about. Or, yeah. I would reach out to primary care and figure out, is there a different antihypertensive that we could switch the patient to so that we can avoid this, especially if they have to be on an oxcarb or carbamazepine.
Great. Well, thank you. That's all the questions that we had. Dr. Zhang, I really want to thank you for your time and the detail you put in putting together your slides. We really appreciate it, and the patient site appreciate it as well. So thank you.
Thank you so much for having me, and great questions. And thank you all for being here.
Okay. Take care, everybody. Good night.
Thanks, Dr. Chang. Okay, bye.
Okay. CO3.